So hello, good morning, everyone. Good afternoon or good evening if you join us from different time zones. So my name is Siani. I'm the Medical Education Manager at WFH. It's a pleasure to welcome you today for today's webinar, the second in the third part series entitled Highlights from the third edition of the 2025 Laboratory Manual. This series is presented in collaboration with the CLAT group. And thank you so much for taking the time to join us today. We are very excited to have such an outstanding professional with us. And we look forward to a great section together. So without further ado, I will start. So first, it's webinar with interpretation in English and Spanish. So if you are using a cell phone, please check the three dots here in the bottom of the cell phone. Click interpretation, the language, and then choose the channel that you'd like to listen your webinar. For person who are using a computer, sometimes you can see interpretation button in the bottom of the screen, and please choose your channel that you'd like it to listen the webinar, okay? So it's my pleasure to introduce Dr. Assad. He is the Director of Humanitarian Aid and Medical Training. Please, Assad.
Thank you very much, Sian. And really, we are very pleased today to welcome you all on this webinars, which, like Sian mentioned, this is an important webinar because, as you know, establishing a good hemophilia care in the country, it starts really by establishing a good and accurate laboratory diagnosis. And we believe these kind of webinars are very important to either draw the attention on the importance of the diagnosis of bleeding disorders, but at the same time, to put some light and strengthen where there are need to put more focus on some aspects. And you will see this from what our distinguished speaker are going to talk today. And I'm very pleased also, like Sian mentioned, that these kind of webinars are a very good initiative that is coming from our laboratory diagnosis committee, because this committee is one of the most important committees in the WFH. Since the start of the committee, they've been involved in a lot of teaching for many lab technicians around the world in how to diagnose. And the latest thing that this committee did is the introduction of the third edition of the lab manual, which is going to help participants here and other lab technicians around the world to improve their knowledge about the diagnosis of bleeding disorders. A special thanks really to the speakers today who are part of this lab diagnosis committee. Having said that, I'm just going to give it back to Sian to introduce the speakers and to go on with the webinars. But I would like, before that, is to also thank the people from the WFH Humanitarian Aid and Medical Training Department, who are really the driving force for all the training activities that we are doing around the world. And I would start to thank my colleague, Dr. Jay Myton, who is the head of the Humanitarian Aid and Medical Training Division at the Humanitarian Aid and Medical Training Department. Sian Souza, who is our Medical Education Manager, and Myrna Hunain, who is our program coordinator for a few important programs, particularly the program of the International External Quality Assessment Scheme, which you will see from this webinar. It's very important to establish an external quality control procedures in each lab in order to be sure of the accuracy of your results. Thank you very much.
Thank you, Assad. So today our panelists will be Dr. Annette from Shelf Lead of Hemophilia Assay in the Department of Coagulation in the Shelf Hemophilia and Thrombose Center in UK. Dr. Neet Matthew, Christian Medical College in Vellore, India, and Dr. Silmara Montalvan from Universidade de Campinas, Unicamp. Dr. Carlos de Braz from Academia Nacional de Medicina, Buenos Aires. He will be our moderator and in the end of the presentation with the questions from the attendants. So before we start, it's important to say that WFH does not promote any particular pharmaceutical product or any mention of any commercial brand in this presentation. It's strictly for education purpose. And here is our agenda. The first speaker will be Dr. Annette with hemophilia laboratory investigation, and then Dr. Neet with von Willebrand disease laboratory investigation, and for the end, Dr. Silmara with inhibitors. Of course, in the end or during the presentations, you can text the questions in the chat box or in the QA box. And in the end, we will have an open forum and the speakers have the opportunity to answer the questions that you are for all attendants. Okay, Dr. Annette, I will transfer the control for you and you can start your presentation in a few seconds, okay?
Thank you, Sian, and
You
good afternoon.
You
Can you
can
hear me?
start.
Thank you.
Yes.
Apologies for having no video. Our cameras don't seem to work today. So I'm going to discuss the laboratory investigation of haemophilia and some of the issues that we face when we are monitoring our replacement products. So the WFH Annual Global Survey highlights the issues of diagnosis of haemophilia A and B in some parts of the world. And it does this by comparing the expected number of patients with haemophilia, shown in yellow, with the reported number, shown in blue. And you can see quite clearly there are some areas of the world in Africa and Southeast Asia where there is a big difference between the patients that have been identified and those numbers that we were expecting to see. So some of the reasons for this include distance to a diagnostic centre, lack of availability of reagents or analyzers, or trained laboratory staff. So this is an area that WFH are actively working on. So when it comes to the diagnosis of haemophilia A and B, there are two main assays that we can use for the diagnosis. First of all, the one-stage assay. It's the most commonly used assay worldwide. It's been in use in one iteration or another since the 1950s, and it's based on the APTT. So dilutions of our test plasma are mixed with an APTT reagent that contains contact activator and phospholipids. It's also mixed with a plasma that is deficient completely in the factor that we want to measure. So factor 8 deficient plasma for a factor 8 assay. And then we add calcium and we measure the time to clot. And this time to clot is compared to that of a reference or a standard or a calibrator plasma. So this is an example of what we would see with our assay in Sheffield. we set up different dilutions, usually 1 in 10, 1 in 20, and 1 in 40 dilutions of our test samples. And as we increase the dilution of the plasma, we see an increase in time to clot, as shown at the bottom. The patient times and the reference times are plotted together either manually on graph paper or by the analyzer to quantify the activity. So on this graph, we have clotting time in seconds compared to a nominal factor concentration. And what we are looking to see using a number of different dilutions is to achieve a parallel assay, which this shows here. And then where your test plasma crosses the 100% factor concentration line, you read until you hit the reference plasma line, and then you can quantify a percentage of factor concentration. We then take this percentage value and we multiply that by the value of the reference plasma. So in this example, the reference value is 0.9 units per mil. The result that we've read from the graph is 55%. So the final activity in this plasma is 0.49 units per mil or 49 units per deciliter. On occasion, we may need to change the dilutions that we use in the laboratory to either make them higher or lower. And one of the reasons that we might need to do that is if there are interfering substances in our patient plasma. And these can include lupus anticoagulants, heparins or DOACs, or patients that have a very high titer specific factor inhibitor. For an example, a patient who has a very high titer factor 8 inhibitor, those antibodies can also interfere with our factor 9 assays, 11 assays, factor 12 assays, and we can end up with a low result. So if you only test a single point assay, you won't be able to identify the presence of any of these interfering substances, and you can grossly underestimate the activity that you report for your patients. So the other assay that we may need to set up for measurement of factor 8 in our laboratory is a chromogenic assay. So this assay has been available for use since the 1980s for factor 8, first performed in a microtiter plate, but nowadays many analyzers have the capability to perform an automated chromogenic assay. The commercial kits contain a source of factor 9A and a source of factor 10. The factor 8 is going to come from your test plasma, from your patient or your QC or your reference plasma. And we are focusing just in on the 10A's complex of coagulation here. You get generation of factor 10A, which then cleaves a specific chromophore, resulting in a color development. And it goes from a colorless to a yellow solution. And this change in color is measured by a change in optical density. The more color generated, the more factor 10A was generated in the assay, so more factor 8 was present in your test plasma. And for the chromogenic factor 9 assay, this is a much more recent addition to the laboratory. Again, we are looking at the 10A's complex. This time the reagents contain factor 10, usually factor 11A, factor 8A, and factor 9 will come from your test plasma. And then again, we're generating 10A, we're cleaving a specific chromophore, and we're getting a change in color. And the color changes are compared to a reference plasma to quantify the assay result in the same way as we saw previously. Now, chromogenic assays tend to be less affected by interfering substances because they have a higher initial dilution compared to the one-stage assay, so are usually performed at a single point. Oh, I think the slides have slightly gone into the wrong order. I'm just going to skip forwards one. Oh, no, I'm not. Okay, the slides have got out of order, so I do apologize. Are the differences between our one-stage chromogenic assay For most patients with haemophilia A and haemophilia B, it doesn't matter whether you do your diagnosis with a one-stage assay or with a chromogenic assay, you get equivalent results. However, there is a small group of patients with mild haemophilia A where you get a different result whether you are measuring by a one-stage assay or a chromogenic assay. And this difference can be twofold or more. And it can impact on diagnosis of a patient, and it can impact on classification of the patient. So some patients would be a moderate haemophilia with one assay result, or a mild patient with another assay result. And it's caused by the mutation having an effect on the assays. So these mutations may be in areas around where factor VIII is activated by thrombin, or they can cause instability of the factor VIII molecule, and you end up with a premature dissociation of factor VIII and inactivation. And the methodologies of the assays will highlight these particular mutations. So it's just something to be aware of. What happens when we want to measure our replacement factors with our assays? So again, for most standard half-life molecules, it doesn't matter whether you measure a one-stage or a chromogenic assay, you get approximately the same result. One of the exceptions for standard half-life molecules is Refacto AF. And you can see with the graph at the top, if you measure Refacto AF with certain one-stage assays, certain APTT reagents, you get an underestimation by one stage compared to chromogenic. And it can be up to 50% difference. So one of the ways to get around that is to calibrate your assay using a specific calibrator, a Refacto laboratory standard. And the bottom panel here shows that you can remove the difference between the two assays by using a laboratory standard. This is the side that's got out of order. So if we want to set up a new assay with a one-stage or a chromogenic assay, it's important to establish local reference ranges. And this is much better than relying on either literature ranges or relying on manufacturers' ranges, because it accounts for differences between the reagents used in the lab, which methodology you're using, and different analyzers. So it's recommended that a minimum of 120 normals are used to establish a reference range. But actually, studies have shown that you can get a good approximation of a reference range by using 20 normal donors. It's better to use local donors because that takes into account any ethnic or geographical variations. And it's important to have separate ranges for pediatric and adults. It's also, we should have an approximately equal gender split and a proportionate ABO blood group based on your local population. So what happens if we want to measure extended half-life factor VIII molecules and factor IX molecules? Well, these have had a great impact for our patients in that we have a reduction in the frequency of treatment to reduce needle burden. But from a laboratory point of view, the introduction of these extended half-life molecules have had some issues in the monitoring in the lab. And there are some of the extended half-life molecules cannot be monitored accurately if you use certain APTT reagents. So it's really important that a laboratory has good communication with their clinical team so that they know which products are being used in their patients, and then they can check that the APTT reagents that they use in the laboratory are suitable for accurate monitoring. So for most of the extended half-life factor VIII molecules, a chromogenic assay will accurately measure your factor VIII activity. However, for the ultra-large half-life molecule Altuvio, Altuvoct, which has recently been licensed, you need to use a one-stage assay. And you see a similar picture with the extended half-life factor IX molecules, that some reagents are suitable for use and some are not. What about factor VIII mimetics? So in the UK, about 80% of our patients with severe haemophilia A are using prophylaxis with emicizumab Hemlibra. And we know that because of its mode of action, it impacts the APTT and will impact any one-stage assays based on the APTT. There's data from Mymate, which is an alternative from a different company, and we're starting to see data from NXT007, which is the next generation of emicizumab, to show that they all have a similar effect on our laboratory assays. And this table is taken from the summary of product-specific characteristics of emicizumab. So if we look in a little bit more detail, emicizumab binds to human factor VIII, human factor IXA, and it mimics the effect of factor VIII in the 10-ACE complex. And in doing so, it will have the same effect as factor VIII in the APTT, and you end up with a much shortened APTT, even with very, very low concentrations of emicizumab or Mymate, and likely NXT007 as well. And what that means is a plasma calibrated one-stage factor VIII assay will recover very, very high levels of factor VIII in the presence of factor VIII mimetics. And you can see from the little graph at the top right-hand side, these are results in units per mil for factor VIII. And you can see results of 5, 10, 15, so 500 units per deciliter, 1,000 units per deciliter. So very, very high numbers. However, product-specific calibrators are available, which means you can calibrate your one-stage assay with these calibrators and measure drug concentration of emicizumab or Mymate in micrograms per mil. And this is a way of checking that you have adequate cover and the drug is working. What happens with chromogenic assays in the presence of factor VIII mimetics or bispecific antibodies? Well, this table here shows a number of commonly used chromogenic factor VIII assays, and they've been split according to where the reagents are sourced from. So the reagents shown in the lighter blue at the top all contain bovine factor X, bovine factor IXA. And emicizumab and Mymate and NXT do not recognize bovine proteins. So these assays are insensitive to the presence of emicizumab and so forth. And that means they can be used to accurately monitor any recombinant factor VIII, any additional factor VIII that might need to be given to your patient around surgery or bleeding episodes, for example. The reagents shown in the middle in the very pale colours contain human proteins, and these are the proteins that emicizumab and so forth will bind to. And you will get a surrogate or a mimetic factor VIII activity using these assays. And you can use that to show that there are these drugs on board and they are working to a certain extent. And the results at the bottom in the darker blue are kits that contain bovine and human mixed proteins. And largely these are insensitive to the presence of emicizumab and Mymate and NXT. There have been a number of trials looking at the use of a low dose of emicizumab in a way to try and maximize the number of patients that can be helped with a single dose. And one of the queries is whether our laboratory assays are capable of measuring down to very low levels of emicizumab, because the expected concentration for these low dose studies is about 12 micrograms per mil or lower. In studies that I've performed in Sheffield, we can accurately measure down to 2.5 micrograms per mil. So I don't envisage having any problems with measuring in the laboratory these low doses of emicizumab. What about gene therapy? Gene therapy is licensed for use in some countries. There have been a number of patients who have been dosed with gene therapy. There are some differences whether you measure by a one-stage or a chromogenic assay. Chromogenic assays are lower than one stage by a factor of about 1.5 or 2. So it's recommended that you monitor using the same reagents that were used in the clinical trial wherever possible. So to summarise, one-stage assays are in widespread use around the world, but chromogenic assays are increasingly required. You do see differences in some patients with mild haemophilia A, and there are some differences with monitoring extended half-life molecules. You have to be very careful that you know how your APTT reagent acts in monitoring these molecules. With Altuvoct and Altuvio, you must use a one-stage assay currently. And when it comes to bispecific antibodies, such as the Hemlibra, the factor VIII mimetics, you can use either a modified one-stage assay using a product calibrator or a human chromogenic assay to monitor the product. But monitoring of any additional factor VIII will require a bovine-based assay. And it's really important that you have good communication between your clinical and laboratory teams. So with that, I'd like to say thank you very much.
Thank you, Dr. Annette. I will remove the control from you, and I will pass the control for Neat. Just a few seconds. Just a reminder for those who joined after my explanation, you can choose the language you want to listen by selecting English or Spanish channel, okay? So Dr. Neat, you can have the control now.
Thank you very much. Hello, everyone. I'm just waiting for the controls, but till then I will say that I am going to discuss on the laboratory diagnosis of von Willebrand disease. I do not have the controls yet.
Can you try again, please?
Yeah, I think I do now. Yes. So von Willebrand disease, as we know, is the most common inherited bleeding disorder, and the von Willebrand factor is a large multimeric protein that acts as an adhesive bridge between platelets and the vessel wall. So it binds to platelets primarily through the glycoprotein 1b receptor using the A1 domain, and the other side to the subendothelial collagen through the A3 domain, bringing about platelet adhesion. We do have quantitative deficiencies, which can be a partial decrease of the factor, which is type 1 von Willebrand disease, or a complete absence of von Willebrand factor, which is type 3. There are qualitative abnormalities as well, which cause type 2 von Willebrand disease, which are further subtyped into types 2A, 2B, 2M, and 2N. Now, as was mentioned in the previous presentation, if you look at the global perspective, there is a major discrepancy. As in one look, you can understand that it is probably the upper income countries and upper middle income countries where maximum diagnostics and registration happen, even for the von Willebrand disease. And to put it in further, I can tell you that where 40% of the world's population reside, which includes sub-Saharan Africa and South Asia, only 2.6% of von Willebrand diseases are coming from that or registered or diagnosed there. So there is this major discordance between the countries. In 2021, there was a consensus or guidelines released by a panel, including from ASH, ISTH, NBDF, and WFH for the diagnosis of von Willebrand disease. I will be using their guidelines as a template to take you through the tests of von Willebrand disease diagnosis in the lab. So they have actually given an algorithmic approach, which I will try to break down in subsequent slides and go little by little. So when a patient is suspected of having a von Willebrand disease, the recommendation is to apply a standardized bleeding assessment tool, such as the ISTH BAT. And if it is positive, you go ahead and do the basic screening test and specific test for von Willebrand disease. If it is negative, you look at the scenario. Now, there are certain recommendations here. For example, if the patient is first in a primary care setting and the chance or the prospects of this patient being a von Willebrand disease patient is very low, as in 5% or so, then you rely on a bleeding assessment tool score to decide on going ahead with specific testing. Whereas if there is an intermediate probability, such as referred by a hematologist, or a high probability, that is the patient has a first degree related with von Willebrand disease, then you do not rely on a BAT score, but definitely go ahead with the specific screening tests. And those tests are the von Willebrand antigen, the von Willebrand activity, which is the platelet-dependent von Willebrand factor activity, and the factor VIII level assays. So, sorry, going on to the von Willebrand antigen assays. So it's a quantitative assay that measures the total amount of von Willebrand protein present in the sample. Now, this includes both the functional and the dysfunctional forms. The von Willebrand antigen levels can be quantified by immunological methods that include ELISA or latex immunoassay or the chemiluminescent immunoassay. When we look at the assays for platelet binding activity of von Willebrand factor, which is the von Willebrand factor activity assays, there is the rostosertin cofactor assay, the glycoprotein 1b-R assay, the glycoprotein 1b-M assay, and the von Willebrand factor antibody assay. So I will try to explain the first three with the help of this figure. So in a rostosertin cofactor assay, we are using stabilized or fixed platelets with the glycoprotein 1b, of course. And when we add rostosertin and patient's plasma, what happens is rostosertin induces a conformational change in the von Willebrand factor, which enhances its binding to the glycoprotein 1b receptor. And of course, this binding is directly proportional to the activity of von Willebrand factor in the patient plasma. And of course, there will be an agglutination and an increase in turbidity, which can lead to decreased transmitted life, which is further recorded. In the von Willebrand factor glycoprotein 1b-R assay, here instead of platelets, we use microparticles which are coated with recombinant glycoprotein 1b. Now, the R here stands for rostosertin. So this is a rostosertin dependent assay. And similarly, when the patient plasma is added, the rostosertin helps the von Willebrand factor bind to the glycoprotein 1b of the latex particles, and there is the agglutination and further reading. Now, moving on to the glycoprotein 1b-M assay, here again there are microparticles coated with anti-glycoprotein 1b. But here the difference is that the recombinant glycoprotein here has some gain of function mutations, which enables the von Willebrand factor to bind to the platelets without the help of rostosertin. So this is a rostosertin independent assay. And then further, of course, there is this agglutination and the readings can be taken. Now, the risk, for completion's sake, I will mention an antibody assay, a specific anti-VWF monoclonal antibody adsorbed onto latex reagent directed against the platelet binding site of von Willebrand factor, which reacts with the von Willebrand factor of patient plasma. And the degree of agglutination is directly proportional to the activity of the VWF in the sample and determined by measuring the decrease of transmitted light. So to summarize the activity assays, we have the rostosertin cofactor assay, which used stabilized or fixed platelets, and we look at the agglutination of them. There is the glycoprotein 1b-R and 1b-M, which use recombinant glycoprotein 1b on latex microparticles. The 1b-R is the rostosertin dependent test, and the glycoprotein 1b-M is an independent test because of the gain of function mutations of the glycoprotein. The 1b-R has two platforms, a latex immunoassay and a chemiluminescence platform, and the 1b-M is on a latex immunoassay platform. And then you have the von Willebrand factor antibody as well, which is a latex immunoassay. Moving on, just to mention before moving on that this panel, the guideline panel, actually recommends that we use the newer assays such as glycoprotein 1b-M and 1b-R over rostosertin cofactor assay for the diagnosis. But however, this is a conditional recommendation, and we do know that the lower income countries or LMICs, either the latter two platforms are available only in expert labs or not available in certain countries at all, and therefore rostosertin cofactor assay is still being widely used. So moving on, once we have done the antigen and the activity, so if the factor levels are more than 50%, you rule out a von Willebrand disease. And if the levels are less than 30%, the next step is to look at the ratio between the activity and the antigen. Now, if the levels are between 30 and 50% and there is no bleeding, you can still say that there are decreased levels of von Willebrand factor with mild risk of bleeding. However, if there is a bleeding, then you again, just as you would in a less than 30% case, you look at the ratio of the activity to the antigen. If the ratio is more than 0.7, which means it's closer to 1, there is no discordance between the antigen and the activity, and you classify it as a type 1 defect or a type 1 von Willebrand disease. If the ratio between the two is less than 0.7, you call it a type 2 von Willebrand disease. Now, there is a recommendation by the panel which says that the cutoff, the ratio that you use, you should not use a ratio of less than 0.5 and use a higher cutoff, either 0.7 or even 0.6 if certain labs are using it. That is acceptable as well to diagnose or differentiate a type 1 from a type 2. So once we have the ratios in hand, if the ratio of the activity to antigen is more than 0.7, it's a type 1 von Willebrand disease. And if it is less than 0.7, it is a type 2 von Willebrand disease. But now you need to know what is the subtype of that type 2 disease. And therefore, the next test that is recommended to be done is either a collagen binding assay or the von Willebrand factor collagen binding assay. And you look at the ratio of this collagen binding to the antigen, or otherwise, if possible, you can do a multimer analysis. Now, if this ratio, the collagen binding to the antigen ratio, is abnormal, or again, less than 0.7, then you call it a type 2A, or it could be a type 2B von Willebrand disease. And if it's normal, it's a type 2M von Willebrand disease. So what is the collagen binding assay? This relies on the ability of von Willebrand factor to adhere to collagen and is dependent on the presence of high molecular weight multimers as well as an intact collagen binding site. Now, this collagen has a low affinity for single von Willebrand factor binding domains and requires large multimeric von Willebrand factor for a tight association. So this property is utilized to detect the loss of high molecular weight multimers, which can differentiate between type 2A or type 2B, where there is a loss of these high molecular weight multimers, versus a type 2M, where there is a normal multimer distribution. The platforms available for collagen binding assay are the ELISA platform and the chemiluminescence immunoassay platform as well. So if you have a reduced collagen binding to antigen ratio, you think of a type 2A or some cases of type 2B. And if you have a normal ratio between the two, it is a type 2M von Willebrand disease. That brings us to multimer analysis. This is a figurative representation. So you have the different multimers of the von Willebrand factor molecule, the low, intermediate, and the high, which are represented here. In a type 1, all the multimers are present, but in a reduced concentration. Therefore, you have a normal pattern, but maybe in a reduced intensity. Whereas in a type 2A, you have a selective loss of high molecular weight multimers, which can be easily seen on this gel electrophoresis, versus a type 2M, where there is a normal pattern. Of course, in type 2B also, there could be some loss. And in a type 3, you have complete absence of the multimers. Now, the von Willebrand factor multimer analysis is a laborious task, and it's basically SDS, agarose gel electrophoresis-based system. And currently, the most widely used technique is a commercially available semi-automated assay, which is the CBR Hydrasys von Willebrand factor multimer analysis. This method for the detection and analysis of the distribution of PWF multimers in human plasma by agarose gel electrophoresis is described elaborately in the latest WFH lab manual. Moving on, there is the factor VIII binding assay for the diagnosis of type 2N von Willebrand disease or Normandy, and this is characterized by a defect in von Willebrand factor, which results in a reduced capacity to bind factor VIII, which leads to an increased clearance of unbound factor VIII from the circulation. 2 in-house ELISA-based assays have been described, and the latter one is described in the lab manual. To interpret the results, this is again an autosomal recessive disease, and there are homozygotes or compound heterozygotes. When you are a homozygote or a compound heterozygote for this disease, the von Willebrand factor, the factor VIII binding assay will be either absent or markedly reduced, whereas the ratio of the factor VIII binding to the antigen is significantly reduced as well. If the patient is a heterozygous for this condition, it can be the factor VIII binding can be normal or reduced. Similarly, the ratio can be reduced as well. Now, a closest differential here is mild hemophilia A, which needs to be ruled out, or female hemophilia carriers. And in those conditions, the factor VIII binding as well as the factor VIII binding to the antigen assay will be normal. There is one commercially available factor VIII binding assay in the market, which is from Diagnostica Stable. And moving on, if a patient is suspected of having a type 2B von Willebrand disease, the guideline panel asks for an upfront genetic testing, recommends an upfront genetic testing. And of course, if that is positive for type 2 variants, you diagnose a type 2B von Willebrand disease. And if it's negative, you do a ristocetin-induced platelet aggregation, and you particularly look at the response to low-dose ristocetin. And if it is positive, you evaluate for platelet glycoprotein 1B variants for a platelet type or a pseudo von Willebrand disease. And if it is negative, you diagnose it as a type 2A von Willebrand disease. Before concluding, I would like to briefly talk about the utility of bleeding time in severe bleeding disorders. So in this study documented below, where 852 patients were evaluated for a primary hemostatic defect, the sensitivity of the modified IVs method was 100% for Glanzmann, 85% for Bernard-Soulier syndrome, 63% for von Willebrand disease. But you can see that if you look at the von Willebrand type 3 subtype, it is 100%. And moving on to this figure, which is available in the lab manual, you can see when you look at a simple test such as a bleeding time and compare it with a proprietary test and an expensive one which requires an equipment such as a PFA 200, if you focus on the left side of the screen, you can see in cases of severe von Willebrand disease where the factor levels were less than 10, whether it's a severe type 1 or a type 3 or type 2, as well as in a type 3 von Willebrand disease per se, you can see that the sensitivity is as good as your PFA 200 when the test is done in the right context of bleeding disorder patients, and therefore can be used in a resource-limited setting. Therefore, to summarize, I will go by this table, which is available in the manual. Just briefly to say, you have your quantitative defects, the type 1, which is a partial reduction where you have reduced or normal factor VIII levels with reduced activity and antigen, normal ratios, normal multimer pattern, and the other extreme, the type 3, where you have a complete absence, where the factor VIII level is markedly reduced, and you have almost undetectable levels of antigen and activity, and we do not look at ratios here. And then you have the qualitative types, which is type 2 or functional defects. You have subtypes 2A, 2B, 2M, and 2N. And to differentiate the 2A versus the 2M, the recommendation is to do a collagen binding assay. And if the ratio of the collagen binding assay to the antigen is normal, it is type 2M. If it's reduced, to consider right type 2A or a type 2B. And of course, for type 2B specifically, genetic testing is recommended. However, a ristocetin-induced platelet aggregometry can give you a clue. And for a type 2N, you can do a factor VIII binding assay on an ELISA platform as well. So with this, I would like to conclude my talk. Thank you very much.
Thank you, Dr. Anit. I will again transfer the control to Silmara. Please, Silmara, you can test. Hello, Silmara? Silmara? Can you hear me?
Dr. Silmara is muted.
Yes, I'm so sorry. Now I understand and understood what I need to do. Hello, everyone. Thank you very much for this opportunity. Let's see if I can move on the slides. Yes, okay. So now we move on to inhibitor test in hemostasis. We will focus on factor VIII inhibitors. This is a very important issue that we need to discuss for all of us. And thank you for joining us today. First, we start with a brief introduction. Then I'd like to highlight 3 points. Different antibody kinetic, that is important regarding the interpretation. We will discuss some aspects regarding the prenalical conditions. And I would like to highlight some points in protocol of inhibitor test, focus on modify Bethesda assay. Any final considerations? Okay, as you already know, 30% of people with hemophilia A may develop antibodies. In case of hemophilia B, the number is lower, is 5%. Most of these antibodies are IgG4 subclass, and it can be neutralized, that we call inhibitors, or non-neutralizing of the factor activity. Inhibitors act by, inhibitor acts by binding with the factor and either blocking its, my slide's not working more, I don't know why. I'm so sorry.
Sorry.
Yeah,
Yes.
my
No,
slide's not working.
You have the control by my side.
Yes.
Yeah.
But it's not working more. I don't know why.
Okay. Let me get the control and I pass for you. Okay.
I think I'm passing. Yes.
Yeah.
Now it's sorry. Inhibitor acts by binding with the factor and either blocking its action in clot or removing it from the circulation. When we're removing it from the circulation, we're talking about non-neutralizing factor activity. The classification is regarding the title of you can have at the laboratory. We can classify it as a high response when you have titer higher than 5 Bethesda unit. And maybe it's sometime you have and sometime not, but if once you have these patients, it will be classified as a high response. On the other hand, the low response is when you have lower results from the 5 Bethesda unit in all of the time. We also have transient inhibitor that can disappear spontaneously in a couple months in some situation. Why it is important to understand that? Because we can change the strategy of the patient treatment. So high responsive inhibitor show us an anamnestic response, important anamnestic response to factor infusion. And in this setting, we need to move on the treatment to bypass agent, or the patient can be beneficiated with an immunotolerance induction therapy to eliminate the inhibitor. On the other hand, if you have a low response inhibitor, we can keep the factor product treatment, and in this case, you just need to increase the dose. Okay. My first point here, I'd like regarding the laboratory, I'd like to pay attention in the antibody kinetic, because we can change the interpretation depends on the type of kinetic we have. We have two types. We have type 1 inhibitor kinetic, when we usually to have two alloantibodies here. It's very frequently seen in congenital hemophilia A patients. And we have, in this case, a complete inhibition of the factor activity. Then, if you have the type 2, the scenario is different. We have autologous antibodies. We can see most of them in acquired hemophilia, but we also can see in congenital hemophilia patients. In this case, the inhibitor is unable to inactivate the factor completely. So why this is important to understand? Because in some situation, the APTT test, the mixed APTT test, to identify the inhibitor may give us a normal results. In the Bethesda assay, if you understand the kind of scenario we have, we need to to get a different interpretation regarding the final results. Here we have a good example of that. We have here in the first line, one Bethesda title, a low responser maybe. We have with this title of the antibodies, a marked abnormality in APTT and APTT mixing test, as you can see regarding the seconds. When we move on to the strong Bethesda title, as this example, 120 Bethesda unit, we have here 69 seconds is a minimal modification on the seconds about this APTT test. And in the mixing test, we can also see it. So here we can see no correlation between the results of mixing APTT test and the inhibitor title from the Bethesda assay. This is a typical situation when you have the Cynetica type 2. So in this case, you need to pay attention to do the right interpretation. Regarding the Bethesda assay, we need the same situation regarding the pH, what you need, what you are looking for. Just to explain in this situation, I'd like to remember that when you have one Bethesda unit, it corresponds to 50% of neutralizing factor activity. And for this reason, in this assay, we're looking for the dilution that you can find the 50% of neutralization of the factor VIII. Here in the type 1, we can see the plasma A. And in different dilutions, you can have different levels of the factor VIII, of the residual factor VIII. And if you do the calculation, we can move on to the final results, and you can see similar results. This is on a picture that you can find in the type 1. When you move on to the type 2, the situation is different because in residual factor VIII, as you can see, the result is similar between different dilutions. And when you do the calculation, the final results will be very, very different from on the other. In this situation, we need to use the lowest dilution for the patient results. This is an important situation that you need to pay attention. Now you need to move on to a more practical point. I'd like to tell about the pre-analytical conditions, and one situation that is important with some scenario that you can happen in some countries. Many countries with limited resource, samples need to be sent to reference labs for inhibitor testing. And the good news here is that we have this study that can conduce a validation about this issue. And the conclusion of this validation was that sample can be sent refrigerated instead the dry ice conditions. And of course, if they are used only for inhibitor evaluation. But this is an important strategy because if you don't have dry ice, you can send your sample to test the inhibitor, and it can help with a lot of countries to manage the situation in their scenario. Another pre-analytical condition regarding the factor when you have factor in the patient sample. We know that the presence of the factor in patient sample violates the principle of the Bethesda, where patient and control sample must not present the factor before incubation. It can be because we can have presence of residual inductional factor in moderate and in mild hemophilia, or it can be from the exogenous situation when the patient are in the prophylaxis or in ITI protocol. To solve that, we need to heat the sample at 56 degrees Celsius for about 30 minutes before running the test. Here we have an example for patients from our lab. In the blue line, you can see the results from the sample that we heated, and the black line is sample that the same sample that was unheated. And you can see we have a real difference between the results. Sometimes a result that was negative became positive. both shipping samples refrigerated and this setting regarding pre-heating before testing are it's show appear simple, but it's very important to give us a good strategy to interpreting the results. The last point regarding the protocol, functional assay to see the inhibitor, the neutralized antibodies, is the modified Bethesda assay. And you can use two types of methods. We can use one stage and chromogenic assay that Annette already explained us. In some situation, if you wanted to see the antibodies without know even and you have want to know the neutralizing and no neutralizing, you can use the immunological assay such as ELISA or fluorescence. But to see the inhibitors, the only one, the gold standard until now, is the modified Bethesda assay. The original Bethesda method was suggested by Casper in 1975 and later modified in 1995. And the two situations that was important in this modification was buffer the normal pool plasma to improve the factor 8 source or factor 9 and replacing the buffer, the imidazole buffer, with factor 8 or 9 deficient plasma as a reference sample. This modification was very important because here you can reduce the false positive results. The variation in this test, even when you use the modified Bethesda assay, is huge, is close to 30%. So in the steps of when you do the dilutions, you need to pay attention because in this step, we can have some mistakes and we get this kind of variation. So it's important to keep in mind that you need to understand what you are doing in this part of the assay, in the dilution manipulation. The part one, we need to prepare the sample as we already discussed it regarding the written sample. And the part two, we need to see the dilutions. There is several dilution that is, we can see it in the detail in the lab manual. After that, you need to incubate the sample at the 37 degrees by 2 hours. In case of the factor 8, you need to do 2 hours because the antibody is time and temperature dependent. So we need to do this process. And then you can choose which method you use to see the residual factor 8 or 9. A very important situation that I would like to share with you is if your lab already performing factor 8 activity testing, you are capable of performing inhibitor assay. So we need to just understand the kind of buffer we need to produce. But if you do the factor, you have the equipment and the skills that is necessary to do the inhibitor assay. So if you do not have this experience, I would like to ask you to try to do the inhibitor test if you already know how to do the factor. To calculation is not difficult. You need to understand that 50% of residual factor equivalent to 1 Bethesda unit. And if you find this situation in dilution 1/4, your final results will be 4. So depends of the dilution that you can find this 50% of residual factor 8. We also have alternative calculation that is available in the lab manual. Some points that Annette already show us, but it's very important here to inhibitor. You can use the chromogenic method in two situations that you need to use. If you have lupus anticoagulant in your sample, maybe you can have a false positive results and you can use Chromogen to solve it. If you have emicizumab, it's also important because emicizumab can show us a normal results and a normal result, so a wrong result regarding the Bethesda title. In some situations, these specific studies show us that maybe the chromogenic help us to have a better result when you have a low title inhibitor. Just to finish my talk, I just like to explain a little better what happened with emicizumab. When you have B-specific antibodies together with the antibodies that you wanted to see, when you put together with the normal pool plasma, the fibrin that you are seeing at the equipment is due to the presence of the B-specific antibodies. So here you can have negative results, even if your antibody is there. To solve that, you need to use the chromogenic method with bovine reagent because the bovine proteins do not react with the B-specific antibodies, with the emicizumab. In this situation, we can have the right result. Here, just to show you an example from my laboratory, a patient with 84 micrograms by ml of the emicizumab in the plasma, and we can see PT and APTT with a normal results, a shorter APTT. Factor VIII in one stage is over 400 units by deciliters. That is artificially because it's not real. When you move on to bovine chromogenic, we can see the real results from the factor VIII. And regarding the inhibitor quantification, if you use the one stage here, I got a negative result. When we move on to bovine chromogenic, the result was 12. So this is the important situation that chromogenic is necessary. To finish this, here is an example about a patient in ITI protocol that you can see. You could see a positive result to one stage method, while in ELISA method, when you look to IgG and chromogenic method, we could see in all of the points negative results. So here again, the benefits that you have when you have a chromogenic method. To point out the message to take home, we need a modified Bethesda assay to see the inhibitors. This is better than original Bethesda method because it's better in specificity. When you have low positive results, maybe if you have available chromogenic assay can help your routine. And in cases that you need chromogenic assays is when you want to see inhibitor and the patient is treated with the emicizumab or other B-specific antibodies, or when you have together a suspicion of lupus anticoagulants. With that, I would like to thank you your attention. Thank you.
Thank you, Silmara. We have now few minutes only for one questions. Dr. Carlos, maybe you can check the chat box. We have it.
Sí. Buen día, estamos casi pasados, pero hay una pregunta que es coincidente entre dos asistentes, Alexander Burnell y Mirta Hein, que es ¿cuál es el impacto diferencial que pueden tener la enfermedad de von Willebrand tipo 1 versus tipo 3 en los ensayos de una etapa y cromogénico de actividad del factor 8? Y esta pregunta yo creo que es para Aniti, pero sin embargo también podría intervenir Annette, ya que involucra también cosas que ella ha expuesto. ¿Quieren responder, Niti o Annette?
I see the question in the chat box. It is about the what impact would von Willebrand type 1, type 3 have on the one stage versus the chromogenic assay. I'm not very sure about that, but considering that in a von Willebrand factor, the mutation is in the von Willebrand gene and the factor VIII is not particularly affected, which is the site of the mutation in factor VIII is what was responsible for the variations in the chromogenic and the one-stage assay. That part is not affected in this particular condition. So logically or rationally, I would think there shouldn't be a significant difference, but I would like an opinion from Dr. Annette. You have any comments on that?
So we know that patients with type 3 von Willebrand's disease often have factor VIII levels that are low because the factor VIII is not protected from proteolytic degradation by the von Willebrand factor because it's absent. So you often see factor VIII levels of around 10 units per deciliter or lower, and that's the same whether it's a one-stage assay or a chromogenic assay. The same with type 1. There's very little difference between one-stage and chromogenic assays with type 1 von Willebrand's disease. We have seen some differences with Normandy von Willebrand's, but only in a few cases.
Yeah, I concur. Thank you.
So, Carlos, did you see
Muy
any
bien.
other question?
Entonces, una pregunta para Silmara, porque está ahí en el chat. Dice, ¿cuál es la presentación clínica de los pacientes que tienen inhibidor del tipo 2, antifactor 8?
Okay.
La pregunta de Manuel Banor.
Okay, I got it. Okay. Regarding the type 2 inhibitor, we most see it in the acquired inhibitor, acquired hemophilia patients. This is the most common that you see regarding the clinical presentation, but we also can see in congenital hemophilia patients. In this situation, if you have the type 1 and type 2, it's the same for congenital hemophilia patient regarding the inhibitor in terms of the clinical situation, but the point here is if the laboratory doesn't identify that you have the type 2 inhibitor, maybe we can give a wrong result, or we have difficult to give results to the clinician. So here, if you have a type 2 or type 1 regarding the hemophilia setting, the important situation is that the laboratory need to understand that the interpretation should be evaluated with care. In the case of acquired hemophilia, I think the most important setting that I experienced here in our laboratory, when you do the mixing testing, mixing APTT to see if you have or not an inhibitor. In most of the laboratory, some patient with acquired hemophilia shows as negative results for APTT mixing test. And this is difficult to the clinician to understand that we have the inhibitor there and you need to move on to the Bethesda assay. So here you need to pay attention. Maybe you have the mixing test, normal mixing test in this type of situation. But the clinical presentation is you being acquired hemophilia, the presentation.
Okay, I would like to thank you for all the speakers. We already have our time out. So if you have more questions, here is my email from WFH, and I'm in contact with the committed members and the speakers, and I can forward some questions if you'd like it in the future, okay? So thank you very much for this morning. Thank you, speakers, for this contribution. It's really, really good. See you soon. We have in next month the third webinar of this series. So next time talk about platelet molecular genetic analysis. So if you'd like it to participate it, we are going to share the link, the Zoom link soon as our social media, and it will be in December 4th. Okay, so see you soon, guys. Thank you very much, and have a nice day. Bye-bye.
Bye-bye.
Thank you.
Thank you.